This introductory slide mentions the various concepts we will discuss in this PowerPoint presentation, beginning with heart failure. Then we will also discuss pulmonary edema, cardiomyopathy, and cardiac transplant. Heart failure is the form of systolic or diastolic ventricular dysfunction. It results primarily from systolic hypertension and ischemic heart disease, which is abbreviated as a capital IHD. Okay, so the primary causes of heart failure is hypertension and heart disease, ischemic heart disease. So it's very important that we monitor blood pressure and cholesterol fastidiously. That means very closely. Fastidious blood pressure and cholesterol control are the primary preventive measures for those at high risk for heart failure. Now, I purposefully included this picture of a horse carrying a heavy load. This horse is carrying a heavy load of sandbags, for example. And we can think of this as the left ventricle trying to advance the flow of blood, the load, the preload in the ventricle. Okay, so you can see, does this horse look healthy? No. Of course, a normal horse, somebody with a normal heart, could advance this cart with a heavy load. Okay, somebody with a normal heart can manage to move the blood forward from the left ventricle. Okay, the entire, the ejection fraction, whatever it needs to advance, it can move the blood forward. But here we see a picture of an unhealthy horse or an unhealthy heart. It's weak. Okay, so I want you to think of heart failure. I want you to think of this horse that is struggling, because that is exactly what's happening in heart failure. The heart, the left ventricle in particular, because that is, as I always say, the workhorse of the heart is the left ventricle. So make sure you can visualize this horse that's weak and struggling to advance the load, which in terms of the heart would be blood volume, and move it forward. So I like this picture especially because you see that by putting another load, another sandbag on this cart, is that going to improve the horse's ability to move the cart forward? Well, of course not. Okay, so we do not want increased volume in our heart patients. Our heart patients with heart failure are already struggling to move the blood forward. So I will emphasize here, the last thing they need is more volume to try to move forward. By them getting more volume in the left ventricle means that they won't be able to move it forward, and it will instead be backing up and increasing pressures we'll just say in the lungs, because completely backwards, it's going to have more pressures. Okay, you can almost think of it using the analogy we have here. When you increase volume in a heart failure patient, you increase a sandbag here, it's going to fall off the cart. Okay, it can't, the horse can't already pull it. It's going to fall off, and it's increasing pressures so that blood is not moving forward. Instead, the blood that's coming to the left ventricle is backing up. It's falling off the cart and preventing increasing pressures behind the cart. Okay? I will just repeat here as we go on forward and talk about heart failure. when I say the word heart failure, I want you to think of, and this is a normal heart in this slide, but what I want you to think of is a big boggy heart. Okay, it's overstretched, the walls are thinned and weakened. Okay, they are losing their ability to contract. There's not a strong contraction. Okay, so think heart failure, think of a big boggy heart. Okay, and I want to make that emphasize this to you because we're going to be talking about a lot of different heart conditions going forward. And this is one that is actually affecting the structure of the heart muscle. Okay, and of course its function, because when you alter the structure by having the thin, weakened walls, you are affecting the functioning and the ability of that heart to move blood forward. Okay, so we'll move on from there, but these are the things I want you to come back to in your mind. Heart failure is different than heart attacks. It's different than electrical arrhythmias. Heart failure is a structural abnormality now because this heart has enlarged. For the most part, that is the type of structural changes we see with heart failure. The majority of them are the overstretched type. Now, congestive heart failure, sometimes CHF, that's the old term, but we've moved to HF for just heart failure. It is not a disease, so make sure you understand that. It is not a disease. It is the end result. It is what happens because of other diseases that the patient may have. Most often, it is associated with long-standing hypertension and coronary artery disease. Okay, and we've already studied hypertension and coronary artery disease, so that is why we like to put that first, so you have a real understanding of those diseases that lead to or result in heart failure. Now, heart failure results in a characteristic pathophysiology. Remember that the prefix patho means disease. Okay, it's characterized by left ventricular dysfunction. And as a result of that, the patient has a decrease in their quality of life because they have reduced physical activity tolerance. Okay, they also have a shortened lifespan. I'm not sure if I have it on another slide, but truthfully, by the time an individual is diagnosed as having heart failure, the stats indicate that about 50% of them will not live beyond 5 years. Okay, so they do have a shortened life expectancy. It's not good news if you get the diagnosis of heart failure. Okay. And again, the picture here is another picture that can visually come to mind when we talk about heart failure. This is the problem. We have a big boggy heart. It's working so hard to move the blood forward, to oxygenate and perfuse the entire body. And that is why they have activity intolerance, because they're not able to get oxygen and perfuse their whole body. And especially with those increasing pressures moving into the lungs, fluid can build up, and then they're short of breath. Now, it's never an item that we test on in terms of the number of people or the incidence of the various illnesses we talk about. But the point of this with heart failure is to tell you that a lot of people in the United States have heart failure that are in the hospital. In fact, if you look on this slide, the fourth bullet point down says that it is the most common reason for hospital admissions in adults over the age of 65. And of course, living in Florida, we know we have a large population of people in that age range. So it is very common. We definitely see it. And the truth is, none of us as nurses working in the hospital or even in clinics will not encounter patients with heart failure. Okay, it's almost inevitable that you will encounter and deal with and treat our heart failure patients. Okay, it is the most rapidly increasing form of cardiovascular disease. Okay, they put it under that title of cardiovascular disease, although it is not a disease, as we just said in the previous slide. It is a result of other diseases, but it is rapidly increasing, and it does, of course, affect the cardiovascular system. And right here, I will also tell you, you can get better statistics in the videos that were supplied as resources for you in this unit or module. In this perfusion module, you have an excellent resource for the Khan Academy, Khan, and they have a lovely video series related to cardiovascular disease, including heart failure. So they will give you the latest statistics as to how many or the incidence of heart failure. In heart failure, the heart cannot effectively fill or contract with adequate strength. So this person has impaired myocardial contraction. Okay? As you see in the picture, the heart muscle is weakened. The majority of the time it's very thinned and weakened, or it can be very stiff. Either way, it's not going to produce an adequate contraction of the heart muscle. And then it shows you in this picture as well, that causes pressures in the heart to increase. Those pressures, as blood fills up, increase, and then blood that's normally supposed to be flowing into the left side of the heart actually start backing up. Okay, because of the impaired myocardial contraction, the cardiac output falls. Okay, and we've already discussed cardiac output. That's why I want you to have a really good understanding of that concept of cardiac output. We said normally an average would be about 5 liters per minute, but that is not the case with heart failure. Okay, because the cardiac output falls, it leads to decreased tissue perfusion. And that's what this whole unit is about. We talk a lot about perfusion in this last semester here. Cardiac reserve falls. Cardiac reserve is the ability of the heart to increase cardiac output to meet metabolic demand. Now, all of us with healthy hearts could go out and walk around the campus, and our heart would be able to respond by increasing the cardiac output because we are increasing our metabolic demand for oxygen as we exercise. But with heart failure, they lose their cardiac reserve. They are unable to meet metabolic demand. Okay, because the patient with heart failure has little or no cardiac reserve and does not tolerate physical or psychological stress, the primary goal for this client with heart failure is to achieve stable activity tolerance. Okay, I highlighted that because this sometimes is a test question. If you understand that heart failure is not curable, okay, we cannot cure people with a diagnosis of heart failure. It's progressively going to get worse. So a goal would be, actually, the primary goal for this patient is to achieve a stable activity tolerance, since that is what affects their ability to live a decent quality of life, we certainly would want to achieve that with and for them. Okay, so let's talk about common causes of chronic heart failure. This is something that occurs over decades, so that as the older we get, patients can present with heart failure. And I would say that coronary artery disease and hypertension are the leading causes of heart failure in the United States. While there are many causes, as you see on this list, you are expected to know the most common causes, those number 2 causes as I have here, coronary artery disease and hypertension. You're expected to know those as being common causes of heart failure. So the number 1 cause, and it's on this list, of heart failure is coronary artery disease. Let me explain how this occurs. Coronary artery disease reduces coronary blood flow and oxygen delivery to the myocardium itself. This leads to myocardial hypoxia and impaired function. Let's see. Let's talk about other factors that are on this list, including valvular disease. It's on the bottom, but is very, very common. And congenital defects also go in that list. Congenital heart defects you see on the list. Okay, they place increased demands upon the heart that can precipitate failure. Cardiomyopathies of known origin, that means if it's a bacterial or viral infection, oftentimes leads to cardiomyopathies, or whether the cause is unknown or idiopathic, cardiomyopathies can lead to failure, heart failure. And myocarditis, which is not really on the list, but can have a similar effect. I would like to add one other thing here about hypertension, that with hypertension, the heart muscle is damaged by the long-standing excessive workload on the heart. Okay, so remember, think back to our cardiac output lecture and the black arrow that represented hypertension as increasing afterload. And so that means that that heart has to work harder, and that leads to damage when that is long-standing, that hypertension. Now, heart failure can also be acute, and we have another list of common causes of acute heart failure. Again, I want you to remember the most common causes in this slide with acute heart failure. The number 1 cause of acute heart failure is heart attacks or myocardial infarction. Okay. Infarcted tissue does not contribute to the generation of mechanical activity, so overall cardiac performance is diminished. In other words, when a common cause of acute heart failure is myocardial infarction, which is the final and often fatal culmination of coronary artery disease. So in other words, coronary artery disease can lead to heart attacks, and the infarcted tissue that results is weakened, and even if the patient survives the heart attack, then you can have scar tissue replacing healthy myocardium, and therefore the overall pumping action or performance of the heart is lessened or diminished. Okay, it doesn't have good contractility anymore. So this picture really represents that very well. We'll get more into it, but understand that a myocardial infarction doesn't have anything to do with the myocardium. Instead, it is an occlusion of a coronary artery. You see the little blackened area of the coronary artery, which happens to be the left anterior descending in this diagram. That means the blood flow distal to that is not getting there. Okay, so that tissue distal to the occlusion is becoming ischemic and then necrotic as the heart attack evolves. What necrotic is the death of that tissue. The death of the tissue never becomes anything except scar tissue. All right, and scar tissue certainly cannot contract and help to advance the flow of blood in the ventricle. So again, it is non-infarcted regions, those other areas around the blackened area, the non-infarcted regions must compensate for the loss of function, and that puts an extra burden on the heart, and which can lead to changes that lead to heart failure. Now we see in the list there are other things. Underneath heart attack, or AMI, acute myocardial infarction, we see the word arrhythmias. Now, arrhythmias such as severe bradycardia or tachycardia can also precipitate acute heart failure. Okay, and there are many other diseases listed there that can lead to acute heart failure. Okay. So, regardless of the cause, acute decompensated heart failure typically manifests as pulmonary edema. And pulmonary edema is an acute, life-threatening situation in which the lung alveoli become filled with fluid. The fluid is a serosanguinous fluid. Okay? The most common cause of pulmonary edema is acute left ventricular failure secondary to coronary artery disease. And I want you to understand, this picture shows it beautifully, how blood overfills in the ventricle because of that damaged heart muscle, and then the blood overflows back into the lungs, causing pulmonary complications. Okay, and it fills the alveoli with a serous fluid, which is the liquid portion of the blood, and tissue fluid, and also the capillaries around the alveoli are disrupted, so we have some blood in there as well. So it's a serosanguinous fluid in the alveoli. So this is an exacerbation of heart failure, will lead to shortness of breath because of this pathophysiology that we show in the slide. So understand, this is how patients with heart failure present. They are short of breath is the most common symptom. Sometimes they will say that they just feel so tired. Okay, that's the patient's way of explaining this. Truthfully, it's hard. They don't come in and say, I feel short of breath. In fact, a lot of times they might deny that. I know I did one time when I had shortness of breath because of bronchitis. I was like, well, I wouldn't say it's short of breath, but I feel like I have to stop to catch my breath. I'm like, okay. So they say different things, but we will interpret that in healthcare as being short of breath. especially with activity. Remember, when they become dyspneic with exertion. So again, you should know that acronym. We use it a lot in healthcare. Capital DOE, dyspneic on exertion, is how we express shortness of breath with activity. Okay. And I wanted to make the point that although they present with respiratory symptoms, the problem is not with the lungs. They do not have a lung disease or pulmonary disorder. They have a cardiac disorder. Okay, so make sure, we always have to make sure, and that's why we do all of our assessments and diagnostic tests to see what is the cause of the shortness of breath. I mean, they may have pneumonia for all I know, but when they come in, for example, to the emergency room, but we have to identify if it's heart failure, the problem is not the lungs. The problem is the heart. And we will want to treat the heart because we need to get the heart beating more efficiently so blood doesn't back up into the lungs. Okay, so heart failure is usually manifested by biventricular failure. That means both ventricles fail. Although one ventricle may precede the other in dysfunction. Okay, so that's a very important concept for you to understand from some of the questions I've been receiving from students. They get confused because the symptoms between right and left heart failure overlap. Well, the fact is they do, because it's unusual to have, well, I'm not saying unusual, but oftentimes heart failure is manifested by both ventricles failing. So then you're going to have symptoms of both right and left-sided heart failure. Okay. Now, as I just stated, oftentimes one ventricle fails before the other, but then eventually the other one fails too. So then you have the whole heart is failing, both ventricles. Okay. So it's not a clear line of distinction all the time. Sometimes it is, but oftentimes it's both ventricles are failing. Okay. The most common form of heart failure is left-sided heart failure. But remember, left-sided heart failure frequently progresses and leads to right-sided heart failure, and there you go, now you are in heart failure. Okay. Biventricular heart failure. But frequently, the most common form of presentation is starting on the left side. And we'll talk more detail about that. Left-sided failure results from left ventricular dysfunction, which prevents normal blood flow and causes blood to back up into the left atrium and then follow the path backwards and into the pulmonary veins. The increased pulmonary pressure causes fluid extravasation. That means fluid is pushed out from the pulmonary capillary bed into the interstitium, which is the lung tissue, and then the alveoli. And that is manifested as pulmonary congestion and edema. So I'll repeat that one more time because this is a heart failure in a nutshell. Okay. Left-sided failure results from left ventricular dysfunction, which prevents normal blood flow and causes blood to back up into the left atrium and then to the pulmonary veins. The increased pulmonary pressure causes fluid extravasation, from the pulmonary capillary bed into the interstitium and then the alveoli, which is shown as pulmonary congestion and edema. Okay, so just to clarify the word congestion, that's what congestion is. Okay, that's fluid and increased pressures and fluid in that area. Okay. What we see here, ventricular failure, the hallmark sign is decreased ejection fraction. Okay, so first I should tell you what ejection fraction, what the definition is. They abbreviate it as a capital EF, and it is always a percentage. Okay, so that's why it's a fraction. It's a percentage. Ejection fraction is the fraction of total ventricular filling volume that is ejected during each ventricular contraction. We stated earlier that we don't want 100% ejection of the volume in the ventricle, otherwise the ventricle would collapse and we wouldn't be able to get blood into the ventricle again. Ideally, a normal ejection fraction is anywhere from 55% to 70%, but not more. Now you will see different values and numbers, but if they fall within that range, that's all acceptable. Okay, so normal, 55%, we're good. Okay, maybe even in this picture, we see 45%. All right. Well, so I'm not really clear what that picture is showing you, but that is a normal ejection fraction. Approximately 0.55 or 55% is a normal ejection fraction. What we're going to look at in our heart failure patients are ejection fractions that are much lower than that. Okay, and I'm trying to see if I talk about it later. Well, I'll just say it now. I may have said it before, but that ejection fraction, when it falls to like 25%, this individual is having a decrease in their quality of life already. Okay, they're already struggling to do routine daily activities. They're short of breath with exertion with a 25% ejection fraction. And that means in real terms, for example, the one we commonly use is if the patient is at home and they walk from their house to the mailbox and maybe back, they're short of breath. Okay, that's so you can see how that really impacts their quality of life when they need to lay down or to, well, not necessarily lay down, but they need to rest, even with that short walk to the mailbox. Okay. And then if you have even less, we see in the hospital quite a few patients with an ejection fraction even less than 25%. Oftentimes they will have, if they're waiting for a heart transplant, they may have a 5% ejection fraction. And then they are laying in bed in the hospital and they are short of breath just laying there without any exertion at all. Okay, so we have a whole range, and as the ejection fraction falls or declines, we see that they can tolerate less activity. Sometimes even talking is considered an activity that makes them have to stop talking so that they can catch their breath. Okay. Some of these patients with such low ejection fractions are in the cardiac ICU. And being taken care of there. Perhaps they are waiting for a heart and they need some additional treatment to keep them living until they have the hope of a heart coming in. Okay, now we're going to talk about two terms. In heart failure, frequently these terms are used to describe the process. We have both systolic failure and diastolic failure. On this slide, we're going to concentrate on systolic failure. And this really is what we've already been talking about in terms of it's when there is an impaired contractile function. Okay, remember when the ventricles cannot contract well, that is referred to as systolic failure. Remember, systole is the result of the contraction phase of the heart. So systolic failure refers to impaired contractility of the heart ventricles, okay? And frequently this is caused by a heart attack. Remember, we use that as an acute example of heart failure. So myocardial infarction certainly can result in systolic failure or impaired contractility. Another big one that leads to systolic failure is hypertension. And the picture here shows it very well with the black arrows in the aorta. Okay, hypertension is one factor that can increase afterload. In other words, the left ventricles, the ventricles must constrict or contract much stronger to overcome that resistance of hypertension. So afterload again is the amount of resistance that the left ventricle must overcome in order to make the blood flow forward. And then also certain cardiomyopathies, which we'll discuss later in this presentation, and mechanical abnormalities, a common cause of systolic failure. This is our valvular heart disease. Remember, when the valves are not opening or closing properly, blood flow is affected. Remember, blood flow needs to occur in one direction, and when you have these valvular abnormalities, we have backward flow of blood, and that causes a systolic failure. Now, diastolic failure occurs less often than systolic failure of the heart. The definition for diastolic failure is impaired ability of the ventricles to fill. Remember, the ventricles must fill with blood. And diastolic failure results in decreased stroke volume. Remember, cardiac output is equal to stroke volume times heart rate. If you decrease the stroke volume, you're going to decrease cardiac output. And isn't that indeed the definition of failure? Okay. So it results when there's diastolic failure, it's because the ventricles are not allowed, or they're not able, I should say, to fill with blood, resulting in a decreased stroke volume and a decreased cardiac output. So the difference is a big difference between contractility in systolic failure and ability to fill the ventricles in diastolic failure. Okay, so diastolic failure is characterized by high filling pressures. It's also characterized by venous engorgement, and it's diagnosed on the basis of pulmonary congestion and pulmonary hypertension with a normal ejection fraction. Okay, this truthfully gets a little beyond what you need to know for your nursing curriculum. But I'm going to mention it here because you will see it in the hospitals during your clinicals at times if you have cardiac patients or cardiac units on your rotation. Okay, again, diastolic failure is not as common as a systolic failure, but diastolic failure certainly does occur. And what's unusual about diastolic failure is that you have a normal ejection fraction. Okay, so when they go for their echocardiogram, you're not going to get a value that indicates that they have a low ejection fraction. Just the opposite of what you would see with systolic failure. With systolic failure, you have a decrease in ejection fraction. Okay, and that's easy for us to visualize, and we're very familiar with that. But here, this patient has heart failure, yet they have a normal ejection fraction. Okay, so let me give you these acronyms. I wish I could write them on the board, but let's put them up there. There's such a thing as HFrEF and HFpEF. Okay, so let me see. The first one is a capital HFrEF, and they say HFrEF. That stands for heart failure with reduced ejection fraction, and that would be your systolic failure. The other one is HFpEF, okay, capital HFpEF. HFpEF stands for heart failure with preserved ejection fraction. And that's what we see with our diastolic failure. Okay. If you find that all too confusing, then I would not stress about it. But maybe in your readings and when you watch videos, it will become clearer to you. I just want to let you know and make you aware of the fact that there are heart failures that don't have a decrease in ejection fraction, but instead the ejection fraction is preserved. Okay. Now, diastolic heart failure is generally the result of long-standing pulmonary disease. So you might just want to circle that there. That pulmonary diseases often will lead to diastolic failure. Okay? So this is a nice slide to help you visualize diastolic heart failure, because here it can result from a left ventricular hypertrophy. Here's a cross section through the heart, the myocardium, and you see that thick myocardium, that's the left ventricle. Okay, look at the ventricle, the size of it, very small. And as a result, when that left ventricle fills, it has diminished filling ability. Okay, it can't hold much blood. So stroke volume is diminished. So diastolic failure, inability to fill, is the result of left ventricular hypertrophy. And there are many conditions, as you see in this list, which can lead to left ventricular hypertrophy and diastolic failure. Most often, I think the one that we'll focus on here is chronic hypertension. Okay, and some people in response to chronic hypertension develop a thickened myocardium, and that leads to decreased filling of the ventricle, a decrease in stroke volume, and a decrease in cardiac output. Okay, so that is that type of diastolic failure as well. Now that we've discussed the pathophysiology, we're going to talk about signs and symptoms of heart failure. One of the earliest symptoms is fatigue. Now, the patient can describe that in many different ways. Again, I just want to point to that fact that they're not going to all come in and say, I'm fatigued. They may say other things. Gosh, I've just been so tired. I just don't have the same energy that I used to. I mean, they say all different things, but it is showing that they are fatigued. So that's one of the earliest signs and symptoms. So left-sided heart failure is often caused by coronary heart disease and manifests as fatigue and activity intolerance, dizziness, syncope, dyspnea, shortness of breath, cough, and many other signs and symptoms that we will discuss. But it is worth stressing that the earliest sign is that of fatigue. And that is because there is a problem with perfusion. The perfusion issue, the oxygenation to the tissues, results because there's decreased cardiac output, which impairs their circulation and decreases oxygenation of the tissues, all of them, cerebral tissue, skeletal tissue, cardiac tissue, and also frequently they will also have an accompanying anemia. So between those two things, because there is an anemia of chronic illness, so if this is a chronic condition, you can also have that anemia as well, and especially if the kidneys are not being oxygenated. Or there's been damage to the kidneys, I should say. A common sign of heart failure is dyspnea. Dyspnea is shortness of breath. Its breathlessness is often worse during exertion or while lying down. Waking up breathless at night is also called orthopnea. It is shortness of breath experienced while lying down. That is a telltale sign of a weakened heart. Okay? Patients may prop themselves up on pillows and sit upright to breathe comfortably. Okay, so paroxysmal nocturnal dyspnea occurs while they're asleep. Another symptom is coughing. The buildup of fluid in the lungs can result in a nagging cough that may worsen when laying down. Swelling, okay, is also part of this, or edema and weight gain. The feet, ankles, legs, or belly, the abdomen, may become distended as fluid backs up from a weakened heart, begins to accumulate. Rapid weight gain is common. As we mentioned in the previous slide, fatigue is a lack of adequate oxygen to provide fuel to the working muscles, and it can result in exhaustion from even the simplest activity. So I'll just take a moment here to explain what occurs at night, and it occurs to all of us as we lay down at the end of a day. Okay, all that fluid that has third spaced throughout the day, all that dependent edema, for example, that fluid came from our vascular circulatory system. So at night when we lay down, that fluid needs to be returned to the circulatory system. And it does in the normal person. It is returned to the right side of the heart through the lymphatic system. That's the lymphatic system that takes tissue fluid and returns it to the right side of the heart. Okay, in a normal person, that's great. But if somebody has heart failure, at night, when they're returning fluid from the periphery, from our lower extremities, and returning fluid back to the right side of the heart, what are you doing? You are increasing the preload. Okay? That's like throwing some more sandbags on top of that working and failing horse who's trying to pull the cart forward. Okay? We don't need to increase preload. That's the last thing we want to do with heart failure patients, as we said before. because giving them more fluid simply means that more fluid is going to back up into their lungs. Okay? That's why they feel like they're suffocating, because now more fluid is in their lungs. They are drowning in their own fluids. They need to sit up. That means that fluid that's in the lungs, basically, I'll say this, but it doesn't work quite this way, drains to the bases or the bottoms of the lungs. That means all that surface area above the fluid is now recruited for gas exchange. So sitting up and gasping for air is going to improve their ability to breathe. Okay, so that's how that works out why they have paroxysmal nocturnal dyspnea. Now we're still talking about symptoms of heart failure. Of course, symptoms will vary depending on how far their heart failure has progressed, right? I should say correct. We said that some of the symptoms are dyspnea, shortness of breath, cough, orthopnea, cyanosis maybe on the late stages when they're not getting tissues perfused. They also, when we're auscultating and listening to their lungs, we hear the presence of crackles, especially inspiratory crackles. We also hear rales and wheezes. We also, when we're auscultating the heart, we may hear the presence of an extra beat. So we may hear with heart failure patients an S3 gallop. I think we've talked about that already. So an S3 gallop could be heard, but I want you to look at these two patients. They are in different stages of heart failure, and I can tell that they're in heart failure because of the fact of what they're doing or not doing in some cases. Okay, so here we see on the left a patient who has herself in the hospital propped up on the bedside table with a pillow. She has assumed the orthopnic position. Okay, I know students like to call that tripod, but the technical term is orthopnic position. This should indicate something to you. This patient is able to breathe better while in this position. Then we have the patient on the right. He too has heart failure. It's pretty obvious to me that this person has heart failure because he is in a motorized chair. Okay, that means any physical exertion makes him short of breath, and I know that because he has supplemental oxygen as well through a nasal cannula. Okay, so when you see sometimes going in Publix and we see patients who are in a wheelchair, a motorized chair, getting around, getting their groceries, is very likely that they have heart failure, and that is the reason why they have difficulty breathing when they exert themselves. So looking at these two patients, the one on the left or the right, which one would you say has a more advanced stage of heart failure? Well, clearly, I would presume that you would choose the man on the right because he isn't able to do any type of activity without being short of breath, and he has the oxygen with him. So the patient on the right definitely is in a stage 4 heart failure because he's using oxygen, he has activity intolerance, and he also, you wouldn't know this, but he has to sit upright to sleep. Okay. So we have to monitor our patients closely with heart failure for the presence of rales, wheezing, crackles, and also monitor them for use of pillows. 1 to 2 pillow orthopnea would be important assessment data in terms of understanding their ability to breathe and their heart failure condition. I want to just say this. I don't think I have any questions for you, but it is in your readings and your videos that there are different staging systems for heart failure. There are two common systems we use for staging our patients in heart failure. The first one is the American Heart Association staging system. Okay, and it has levels A through D. D is the most marked. This patient has very marked symptoms of heart failure at level D. And they may even have a refractory heart failure, meaning that their heart failure does not improve with treatment. It's refractory. And then we have another staging system. It's called the New York Heart Association, and it stages them from class 1 to class 4. And in class 4, patients cannot carry on any physical activity without discomfort, and they have symptoms of heart failure or even chest pain in a class 4 staging system. Continuing on with signs and symptoms of heart failure, we have tachycardia. Tachycardia is an early sign, okay? And it occurs because it's the body's attempt to compensate for a failing ventricle. All right, so we need to understand anytime normal physiology is that the heart is going to beat faster when it's not getting oxygen to the tissues. That's the body's natural response to say, hey, I'm not receiving enough oxygen. Could you beat faster? Yes. Okay, so we end up with tachycardia. Remember that heart failure has a diminished cardiac output, and that stimulates the sympathetic nervous system and increases the heart rate. Okay, that's normal physiology. You expect that to occur when there is a decrease in cardiac output for any reason. The body responds with tachycardia. So we can take that as one of our assessment findings for heart failure. Okay, moving right along to another symptom, we have edema. And this may occur in the legs, liver, as we said earlier, the belly, the abdominal cavity in terms of ascites, in the lungs themselves, and even as a pleural effusion. Remember, that's different than the fluid that's in the parenchyma of the lungs or in the alveoli. This pleural effusion is fluid building up in that space between the membranes. So that's different, and so we can have any type of third spacing. Remember, third spacing is that fluid in a place that it's not supposed to be, okay? For example, this fluid is supposed to be intravascular, inside our circulatory system, but it gets pushed out into the lungs because of those high pressures, and it pushes it into the lungs, for example, and also in the periphery out into the lower extremities. Okay, so we have that dependent edema as a result. But all the swelling, the edema, can back up as well, especially if it's right-sided heart failure, into the abdominal organs, such as the liver, and even into the cavity of the abdomen. So there's many places where we have third spacing going on as a result of heart failure. And if the patient is confined to bed and laying down a lot, extra fluid can accumulate in the sacral area as well. I've seen that occur before, and it's a very strange kind of finding, but when there's too much fluid on board in that patient and it ends up somewhere else, that's the term third spacing. They can get 4+ pitting edema, but they don't have to. Any type of ankle swelling would be of concern and an assessment finding with a heart failure patient. In fact, probably, well, maybe it's because of my age, but every time I go to my physician or Primary care provider, when they're doing an assessment, they always go down to my ankles and just give it a little palpation to see if there's any swelling in my ankles. And that's simply because we are looking for any signs of heart failure. Okay? So development of dependent edema or a weight gain of more than 5 pounds in a week will indicate an exacerbation of heart failure. I believe it's in your text as well. It's definitely in some of your articles or reading or your videos, and it'll tell you about the exact amount of weight that you need to be concerned about. But remember that breathing is a priority, nursing diagnosis, right? Your ABCs. Breathing is a problem when you have heart failure. So the main thing we want to make sure is that they're not putting on weight, because if you're putting on 2 pounds overnight in 24 hours, where is that fluid? It's not weight gain. It's not the traditional weight gain. It's fluid weight gain. And that extra fluid is only going to end up in their lungs. That's why that is the concern if you have a heart failure patient. Breathing, their ability to breathe. Yes, I've stated that the problem is with their heart, but they present with problems breathing, and breathing is a priority. You don't live if you can't breathe. So we have to get the fluid out of the lungs. Okay, and we'll talk about treatment later. But the way we get the fluid out of the lungs is by improving the efficiency of the heart, as well as giving other medications that can clear the fluid. Okay, because we want to restore their breathing ability, but we have to address the heart if we want to have this continue. Okay, so weight gain of more than 5 pounds in a week is troubling, and it may indicate exacerbation of heart failure, and certainly a gain of 2 pounds in 24 hours is a problem. Okay, we don't gain pounds in a day. That's not how weight gain typically occurs. You know, fat itself is pretty lightweight, so a pound of fat takes a while to accumulate. All right. Another symptom of heart failure is nocturia. That means that they wake up throughout the night and to urinate, sometimes even 6 to 7 times a night. Okay, I'm not talking about just one time. No, when people have heart failure, remember what happens at night when they lay down. All that fluid that's in the third space in their body has to move back into the circulatory system through the lymphatic system. And it does. It returns to the right side of the heart and joins the circulatory volume. That increased volume now is going through the kidneys as well. And the kidneys are, we have an increase in urine output. So now the patient is waking up during the night. Okay. Skin changes. Remember, with heart failure, the problem is with perfusion. It comes back to our basic concept of perfusion. That means all organ systems of the body are not being perfused well, including the skin. And so we can see that as the tissue capillary oxygen is extraction is increased, the skin appears dusky. That's what we see in the picture. Sometimes you might say tan, might describe it other ways, but they like to say dusky. It's cool to touch. The lower extremity there is going to be cool in terms of temperature because it's not being perfused well. It's also shiny and swollen. Okay. So also we have diminished hair growth when the skin is not perfused well. So it is taut. That means tight, T-A-U-T, taut, shiny and swollen, and we can see those pigment changes. Also, we can also see the development of stasis dermatitis that occurs as a direct consequence of that venous insufficiency. Again, perfusion is a problem to all areas of the body, including the brain. So behavioral changes can occur as a result of heart failure and decreased cardiac output. This is important for you to get. You'll have questions like this on your exam. So cerebral circulation is impaired. Perfusion to the brain is impaired. So we end up seeing changes in level of consciousness. The very first level of consciousness, the very first change we see is restlessness. That's your first indication that the brain is not being perfused well. Restlessness, this can lead to confusion and also other changes such as decreased attention span or memory changes. Okay, so cerebral circulation may be impaired with chronic heart failure secondary to decreased cardiac output. And the patient or the family may report unusual behavior, including any of those that we just discussed. Now, those behavioral changes could also be a result of their worsening renal failure, because we do have renal failure can occur, and we have that cardiac renal connection. When there's decreased cardiac output, there is also decreased perfusion to our vital organs such as the kidneys, and that also can lead to the buildup of nitrogenous waste products, which can lead to confusion and things like that. So, whoops. And chest pain is a symptom of heart failure. Heart failure can precipitate chest pain or cause it to occur because of the decreased perfusion of the coronary arteries that perfuse the heart itself. And this can increase the myocardial work. Angina pain can be present with acute or chronic heart failure. Okay, and then you see the picture of the man there. The very common or typical presentation when somebody is having chest pain or angina. And anymore, we like to not ask patients, did you have chest pain? Because frequently they'll deny it. They have a hard time describing it as chest pain. They may say, well, I don't know if it was pain. So we like to instead ask them, have you had any chest discomfort? And they may feel more agreeable to confirming that, yes, they have felt chest discomfort. Okay, and finally, a symptom that we want to talk about are changes in weight. And many factors contribute to that with heart failure. Fluid retention, they can develop ascites and even enlarged liver or hepatomegaly. Oftentimes they have an accompanying gastritis with heart failure. And so they feel kind of nauseous, they don't really want to eat, they have diminished appetite. These weight changes can only be detected through a daily weight. These patients at home must have a scale in their bathroom. They must monitor their weight daily, okay, and keep a running track of it. They should write it down. There should be a place in their restroom, in their bathroom, where they can take their weight and write it down. Oftentimes, there are weight changes. These patients with heart failure will lose muscle mass and also fat, but you really don't notice it because they're gaining fluid. So the only way to monitor weight changes is with a scale. And I can't stress the importance of that enough. One thing that I just realized I forgot to mention, I think way back, when we talked about cardiac output and decreased cardiac output, I want to stress this fact is an assessment finding with patients who have heart failure. Any patient who has a decreased cardiac output is going to have a decrease in blood pressure. Okay, I hope that makes sense to you. When you have a decrease in cardiac output, you have a decrease in blood pressures, because we already defined what blood pressure is. So there's less volume there to press against the vessel walls. So you have a decrease in blood pressure. And a normal physiological response to any decrease in blood pressure is to increase the heart rate. So this is what we see. And when we're doing an assessment on these patients, their pulse strength is going to be diminished. Okay, that goes in line with a decrease in blood pressure. So let's start from the top. Heart failure, we have a decrease in cardiac output, we have a decrease in blood pressure, we have a decrease or diminished strength of pulse. And as a consequence of the decrease in cardiac output, the body responds with an increase in heart rate. Okay, so if we're looking at trends, and we should see as this heart failure progresses, a decrease in their blood pressure and an increase in their heart rate. Okay.